Hello everyone, I'm Dr. Angela Mattke, and you are watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at the Mayo Clinic Children's Center. Twice per month, I host a show about pediatric health topics where we take and answer your questions live. Today we're talking about hearing loss in children and how early identification and intervention is essential for language development. Joining us for this discussion is Dr. Colin Driscoll, an ear, nose, and throat surgeon and department chair and professor of otorhinolaryngology at Mayo Clinic. Dr. Driscoll is also the chair of the board of the American Cochlear Implant Alliance, a nonprofit that promotes research, advocacy, and awareness related to cochlear implantation. It's going to be a great discussion today, so please send in your questions under the Facebook Live video feed, and we will try our best to review them during the live video broadcast. Dr. Driscoll, thank you so much for joining us here today.
Yeah, my pleasure. Thanks for having me.
So I think before we can start our discussion, we need to understand the foundation, how normal hearing works. And I think we have a little diagram for us to use this in explaining it.
Sure. So let's walk through that diagram and
Sounds
how does
good.
it work and
Yeah.
how does it go wrong sometimes.
Right.
So sound comes down the ear canal and strikes the eardrum, which sits at the bottom of the ear canal. And that vibration then is transmitted through the three bones of hearing. There's the malleus, incus, and stapes. And those also reside in the middle ear space. So that's where kids get ear fluid, ear infections, those real common causes of hopefully temporary hearing loss. So that sound then vibrates through the bones of hearing, vibrates that third bone of hearing to stapes, which vibrates the fluids in the inner ear, which is the cochlea. And the little hair cells in there get stimulated, and that mechanical motion gets translated into an electrical signal that then goes down the hearing nerve. So we really think of hearing loss in two different ways. There's that hearing loss that involves the eardrum and the middle ear space. We would call that a conductive hearing loss. And then there's hearing loss in the inner ear, the sensory part. And we can talk more about the different causes in those spaces.
Okay, well, what would be a cause of maybe the conductive hearing loss versus more of the sensory neuronal hearing loss?
Yeah, so in young kids, one of the most common things is fluid in the middle ear space and ear infections. People can get holes in their eardrums, and then you can have problems with the bones of hearing themselves. There's some different disorders that involve those. And a lot of those types of hearing loss are correctable with surgery or time, outgrowing ear infections. And also hearing aids work really well in that environment because the inner ear is okay and they just need more volume.
Okay. What about the sensory neuronal types? And you mentioned how that kind of works. And what would be some of those causes?
Yeah, so there's, again, lots of different causes for why that inner ear doesn't work. And the inner ear is really developed at about 9 weeks.
Wow.
Gestation.
And there's such small parts of the body, too, and such small bones that are
really
involved.
small.
Yeah.
All is really small.
Yeah.
That cochlea is formed really early on in pregnancy. It's a complicated structure, of course, like most of our parts are, I guess. And it's not surprising then that things can go wrong. So there can be developmental issues where things just didn't form right to begin with. And then after birth or at birth, there's, we identify various genetic causes, so that might account for up to 40 or 50% of the children who are born with hearing loss will have some genetic thing that sometimes we can identify those now, and each passing year we get to learn, we know more and more about genetic causes. And then there's other rare things, terrible infections like meningitis can lead to hearing loss. We may talk about CMV, which is another infection that's related to sensory neural hearing loss, either, again, really early in life or even progressive. So there's a whole range of different disorders like that. There are some medications not given so much in the United States, or at least they're given in the United States that are toxic to the inner ear, but we know that they're toxic. We give them at appropriate doses.
Right.
So gentamicin is a well-known one, but worldwide, that's responsible for a large amount of hearing loss.
And then that's a medication that may be given to a child with an infection or that may be premature. They're going to be often given that medication during their NICU course.
Correct.
Okay.
Yeah.
So you mentioned how common the genetic causes are of hearing loss, but how often is hearing loss really identified in children or infants? And when do we identify it?
Yeah. So we've gotten a lot better about this. So in general, there's about 2 or 3 per thousand, 2 or 3 children per thousand who have some degree of hearing loss noted early in life.
Is that at birth mostly?
At birth.
Okay.
And so throughout the United States, newborn hearing screening programs are everywhere, and they've completely changed the landscape of early identification. So if you go back to 1990 or so, only about 10% of kids in the United States underwent newborn screening. That's closer to 98% now. So we do a lot better with the screening. You still have to have the follow-up, though. So maybe you identify it in all the kids, but you need to continue to then manage that. But we're much better at identifying it early on.
Okay. And why is it so important to identify hearing loss early on versus before, 1990, when we weren't screening for hearing loss in infancy?
Yeah, so if you want to learn good or develop good speech and language skills, you have to hear.
Okay.
And there's a critical time window to provide sound to develop language. It's remarkable. The brain development's remarkable. So if you don't have access to any sound, and it's 10 years later and you've never had any sound, if we were to restore sound in some magical way, whether it's cochlear implants or some other thing, your brain's past that time where it can really learn normal speech and language. And we recognize that even as kids get beyond age 2 or 3, we're already missing a window. We start to develop our language skills in utero. Babies are hearing, and they're starting to make these connections and pathways. And early intervention is critical to developing good speech and language skills.
Okay, and in these young children, what would be some of the signs if maybe they passed their newborn hearing screen, but were developing some type of hearing loss right after infancy? What would be some signs for a family to look for in that early first year of life?
Yeah, you definitely need to be vigilant. I think we have some things.
Yeah, we do have a slide.
Slides written out. So, and you can find these things online, but there's definitely milestones that you expect kids to reach at certain points, just like we expect them to walk at a certain point. So, smile when spoken to, notice toys that make sounds, turn, his or her head. It's a little complicated because kids are also very visual, and sometimes parents think their child's hearing, but they're really just responding to the verbal or to the visual stimuli.
Right. In my office as a general pediatrician, I can't think of how many times we found hearing loss in a child where family was not aware of it, and sometimes pretty profound hearing loss in one ear or not the other. So they're looking for these signs. If they have concerns about their child maybe not hearing properly, what should they do?
Yeah, so if there's one really important takeaway, if there's any concern whatsoever, get a hearing test done. The screening evaluations that are done are really pretty good now. Even the screenings in schools pick up a lot of very mild hearing loss that wasn't picked up earlier on actually in screening. But get a formal hearing test done. It's not painful. It doesn't require a blood draw. I, as a ENT surgeon, I never complain about too many hearing tests. It's only too few.
It's very true, and it's pretty inexpensive to do. And in the state of Minnesota, we've actually expanded which frequencies we're testing in the school setting and in the office setting. So it's also something that's part of well-child screens. And so sometimes people will defer that hearing and vision screen. It's something I encourage, because if we don't test, we might not pick up something that could potentially cause harm later on.
Yeah.
Okay. What about, you mentioned early detection is really important. What about a child who may be past their infant newborn hearing screen, but you mentioned CMV, and sometimes CMV is an infection that could cause hearing potentially later. Can you talk a little bit more about that?
Yeah, I think there's more and more studies that have come out about the role of CMV. So I'll see children who have some hearing loss early on, but it's mild. And then over 3, 4, 5 years, we see progressive loss. And it's becoming more clear that some of those cases are related to CMV. Okay. You as a pediatrician may know more about treatment of CMV in kids than I do. But it's something that I think we've learned more about, and hopefully intervention will prevent some of that or delay some of that hearing loss. Okay.
So we've talked about what parents should do and how they should be screened. So what if we do identify some type of sensorineuronal hearing loss? What are what are the potential treatment options available?
So if it's mild hearing loss, then, well, I think just awareness that there's hearing loss.
Okay.
So that in your day-to-day life, if your child's not responding, instead of being mad at them because they're not listening to you,
Right.
it may be they're not hearing you.
Exactly.
And recognize that noisy environments are more difficult for them to hear in. So if the TV's on, the music's on, 3 other kids are making noise, that your child with hearing loss is going to struggle. Making sure that teachers and others who are involved in raising your child also are aware. And that requires, I think, constant reminders. Everybody's aware of the importance of hearing, I think, but it slips your mind because you can't see it. And then, then there's as you move up the amount of hearing loss chain, there's more than just sitting in front in the classroom and awareness, but amplification. So hearing aids remain of fundamental management strategy. And hearing aids continue to improve as a technology. They amplify sound, they turn up sound. In school environments, they can be connected with FM systems, and sound can come directly from a teacher or speaker right to the ears. And we all benefit from that kind of technology.
Absolutely. What about for the more severe forms of hearing loss and specifically cochlear implants? When does that become an option?
Yeah, so as hearing loss either progresses, one way I think about cochlear implants is it's just the next step in a hearing aid. So you've outgrown conventional hearing aids. The next one, a little better, is a cochlear implant.
Okay.
And so one pathway is through that. And then the other is children who are born with significant amounts of hearing loss, or adults, anybody who has a sudden significant loss in both ears, then you may bypass hearing aids because they just don't provide anything. And so there's criteria that we all follow. In young children, it comes down to the hearing levels in part, and then also language acquisition. So you can track language progress and know whether or not a cochlear implant is the right next step. And it's the only way to restore hearing in the inner ear. It's sort of a near miracle kind of outcome. I still don't get it, how it works so well. The cochlea, our hearing mechanism, is extremely complicated. And although cochlear implants are a somewhat complicated device, they're also somewhat simplistic.
Okay.
But our brains are amazing. Our brains figure it out.
Wow. Why don't you explain to us what the cochlear implant does? I think we have a diagram to help us understand that a little bit better.
Yeah, so we can look at the picture. There's different models, you might say. So the most typical structure that people will see if you look up cochlear implant, there's a device that looks like a behind-the-ear hearing aid, a large version of that, and it has a separate wire with a round, what we call coil. So in that device behind the ear is a microphone. It picks up sound, it processes the sound, it sends it down the wire to that coil, and then across the skin, a radio signal is sent to the internal device. So there's a part we put in surgery underneath that. And that information is then decoded really or processed further in the internal device. It's sent down a wire that we've threaded into the cochlea, into the inner ear, and then we directly electrically stimulate the hearing nerve. And essentially, we're bypassing a lot of the parts of the inner ear, the inner hair cells, the outer hair cells, and some of the other things. We're going straight to the nerve.
We have a great audience question about this, and you kind of mentioned a little bit more, but just kind of help solidify. How do you determine when the right time is to get the cochlear implant? This audience question is saying, is it better for her child to get a cochlear implant as soon as possible, or should they wait until they're older?
We almost always implant too late.
Okay. That's a pretty simple answer.
Yeah. In young children, I mean, the criteria are they're all outlined, but it is difficult to know, what is this child specifically hearing? So we look at the hearing thresholds, we look at progression of hearing loss, and we look at language development. Good speech language pathologists can analyze your child's speech and and then follow it. 3 months later, there should have been 3 months of progress, and they're pretty good at mapping that out. If you're not making progress, then we're already behind the 8 ball. And so, yeah, as a general rule, we come in too late, and earlier is better. Cochlear implants don't have FDA approval under 6 months of age.
Okay.
As you know, we do lots of things
Absolutely.
outside of
Lots of
FDA approval. It wasn't that many years ago where kids were getting implanted age 2 or 3, and then we started doing studies. Well, age 1 is far better.
Right.
And you can imagine it's if you don't hear, you're not learning your language. So the earlier you start doing that,
Right.
the sooner you're going to learn it,
Right.
and the less behind you are.
Yeah. Anyone who's had a typically developing child with their hearing and language development knows that, between 12 months to 18 months, their language just explodes.
Yeah.
And it's so rapid. If you're missing that window, I can imagine there's, a great loss that may be hard to make up for later on.
You can't make up
Okay.
for it all.
Okay.
The more delayed you are, early on, with minimal delay, there are quite a few kids with implants who learn language at the rate of their normal hearing peers.
Okay.
Outstanding. Unbelievable
Yeah.
that happens.
Right.
Some are even ahead because they're really working on their language development.
Great.
But then, so the further you delay intervention, you can't catch up after a certain point. You can improve, but you can't really catch up.
Is there a reason why children who may be eligible for not getting or for getting cochlear implants aren't getting them? And are there barriers to them being able to get cochlear implants or knowing about them, the knowledge of them?
Yeah, I think there's multiple hurdles. There's still a lack of awareness, which is it's hard for me to understand because I live in the world and see it.
Right.
But there's a real lack of awareness. There's misinformation. Saw an adult a couple days ago who's clearly would benefit from a cochlear implant. Was under the impression it's brain surgery. It's not brain surgery.
Right.
It's about a 1 hour, hour and a half outpatient operation. But it is surgery, and that's scary,
Right.
Especially if it's your child.
Right.
There's still a notion that, well, maybe I can get away with hearing aids and do well enough, and I don't need a cochlear implant. And like I said, you can delay it. It's usually not a great strategy. There's strong advocacy by some that you should learn alternative communication modes. So if you're born severe to profound deafness, you can learn sign language. Turns out well over 90% of kids that are born with severe to profound hearing loss or advanced hearing loss have normal hearing parents and normal hearing siblings and families. And so most people want their children to try and grow up in the hearing world, which has a lot of obvious benefits.
What percentage of kids in the United States that are eligible to potentially get the cochlear implant go on to get it compared to maybe other parts of the world?
Yeah, there's a fair amount of data. There's still a lot of missing data in the United States.
Okay.
It's really disturbing because we have pretty good newborn screening now. So we identify a lot of kids early on, but then they fall through the cracks. And how many actually, where are they going? What is happening to them? We don't really know.
Okay.
We don't track them well enough, I think. In other countries, that's not true. They have much better organized systems. So in Germany, I'm told, well over 90% of the kids are getting cochlear implants.
In a timely manner?
In a timely manner.
Wow, that's fantastic.
In the United States, maybe it's 50%.
Okay. Are there barriers in the United States financially, or is insurance covering the cochlear implants?
There is insurance coverage
Okay.
For cochlear implants, kids and adults. It's not ideal, of course. It's a fairly expensive device.
Right.
So Medicaid reimbursement might be quite low in some states, which creates a barrier.
Okay.
It's a complicated process to go through. You have to work through a cochlear implant center.
Okay.
You need audiologists who are knowledgeable about cochlear implants. You need speech language pathologists. You need surgeons. So you need a team of people, and that doesn't exist in every corner. So there's that access issue. And
What should parents look for in a cochlear implant center? What if they're trying to choose one for their child? Are there certain things that you would find superior in programs?
Yeah, so volume is a good indicator of quality.
Okay.
The more volume you have, just the more experience you have, the better you tend to be. I think that's across a lot of medicine.
Right.
You have to you balance that a little bit with your location. So it does require a number of visits and periodic programming, and so staying regionally, especially for children, can be beneficial. I'll say that world continues to change as hopefully we're doing more telemedicine sorts of things.
Tell me a little bit about the process after they get it. You mentioned programming, and what are things that parents would need to be monitoring and doing after the device is placed? Yeah,
so after surgery, there's a period of healing up, and then you come back, and actually the device is programmed, turned on.
Okay,
and that's
so it's
when
not
you start
turned
to
on
hear.
immediately.
No.
Okay.
Yeah, so that's probably the most exciting day for lots of people.
Right.
I get left out of it. The audiologists get to do it, but
okay.
There's usually tears.
Yeah, I bet.
And so then that's when you start to deliver sound, and then gradually you can think of it as just turning up the sound over months.
Okay.
And for adults, they'll reach or gain most of their maximal performance in that first 6 or 12 months. Kids are learning language, and it's more complicated, but you start to hear right away, and then you just hear better and better over time as the brain figures it out.
What kind of monitoring is done during that time? Is it with speech and language pathology and audiology or other areas?
Yeah, so it's both.
Okay.
We definitely track the performance on audiograms and the standard testing. And then you always want to be looking at language development. And the most critical thing after implantation is parental involvement, talking, listening, speaking. The more access you have to sound, the better you're going to learn. And there's a lot of data. It's astounding. There's an enormous variation in the number of words kids are exposed to.
Yes. And we know that the more they're exposed to, the better.
Yeah,
right?
30 million.
The 30 million word gap.
You heard that?
Yes.
Yeah. So 30 million sounds like a lot, but it's not hard to do. It's not hard to speak to your child. But sometimes we use short phrases or, dog.
Right.
Well, you could also say there's a small brown dog with the owner and a leash in a park on the bench.
Right.
And you've taken one or two words and you made it into 10.
Exactly. You can tell them what you're doing. You can walk through your day.
Yeah.
I tell parents when they have, even infants, I start telling them, tell them what you're doing. Tell them how you're changing their diaper. Walk them through, because the more words they hear, the better equipped they're going to be, the broader they're enrich their language. Vocabulary is going to be by the time they get to kindergarten, and that's going to be a huge boost to them.
Yep.
Absolutely. What about any side effects that parents may want to know about that are considering cochlear implants?
Yeah, so there's, you can think of the surgery, I guess. Fortunately, surgery has a very low complication rate, but the usual things of maybe an infection, device failure. It's a man-made device. The internal device has no moving parts. Theoretically, it can be there your entire life. It's really strange for me to think that some of these kids I've put implants in at 6 months or 12 months might have them for,
80,
I don't know,
90
80 years.
Yeah.
I don't know. Strange.
Yeah.
Maybe technology has changed enough.
Right.
Some people have some residual hearing. So you'll have some hearing, but it's not very good.
Okay.
Somewhere around half the time, with today's technology, about half the time we'll lose that hearing. So you have to be willing to trade your hearing aid in for a cochlear implant. From my standpoint, when we've done the testing, we know whether this is going to be a good trade or not. So I know whether it's a good thing to do. That at the end you're going to hear better with the implant than you do with the hearing aid, but it's scary.
Right.
It's scary to give it up.
Absolutely. How often do the devices need to be changed out, or is that something that has like a long time life?
So a lot of the important parts is in the external.
Okay.
So a lot of the processing things, so those can be upgraded periodically, and companies keep coming out with upgrades there, as you might imagine. The internal device is meant to last a long time, because the last thing we want to do is have to do another surgery just to replace the internal device.
Absolutely. Well, anything else you want to mention about cochlear implants? Or information for families or advice for them?
Yeah, so I think you want to go, if there's concern about your hearing loss, the amount of hearing loss, you go to a Cochlear Implant Center, understand what the technology is. There's a lot of information online too. Some of it is good, of course, some is less good. But really try to understand the technology and what it has to offer. And timing is important. Waiting is an issue. And so, well, let my child grow up and they can make a decision. There's a missed opportunity. So I think whether you choose a cochlear implant or not, it's a different story, but being really educated about it and making that decision early.
Absolutely. We have a couple audience questions that don't relate specifically, but I want to get to those before the end of our broadcast. Great question from a family member who has one child with hearing loss and wondering what the likelihood of subsequent children developing or having a similar hearing loss would be.
Yeah, so that's a great question for the geneticists. And unfortunately, there aren't a lot of geneticists in the United States. We have a great one here, Dr. Scamenti. So all of our children with hearing loss will see her and a lot of the adults, and we can do the testing, and she can give you a pretty good idea what the risk is. Depends on whether it runs in the family, if this is just an isolated thing, so it can be 25%, it can be 50%, it can be way less than that, so it really depends on the cause.
Yeah, so the family could meet with the geneticist and kind of help determine risk for them. Could be a good option. Okay. And then the last question was about more external structure of the ear canals. Does stenotic or narrow ear canals, does that cause hearing loss?
If they're narrow enough, it does.
Okay.
Some children are born without ear canals, and we have options for that. Some people just have narrow ear canals. It really doesn't have to be that open to transmit sound. So even at 10% of the normal size, probably going to have normal hearing. The problem is people have wax,
Right.
and it then blocks up a narrow ear canal more easily. And so we do widen ear canals to try to make them more functional that way and less likely to get blocked up. And for kids without ear canals, there's either an option to reconstruct the ear canal, which then maybe it improves the hearing, or at least improves it some, or allows the use of a conventional hearing aid in the ear. Or there's other devices, the Baha, a bone-anchored hearing aid, which attaches to the bone behind the ear. And it doesn't require an ear canal. It just goes right to the inner ear.
Okay.
So another device.
So there are definitely options for those children.
Yep.
What are some resources that you would recommend to families? What websites would you recommend if they're looking for information?
Yeah, I think we have a graphic somewhere of a few websites. Again, there's lots of information on the web, but these are some places you may want to start. And ultimately, I think maybe on the internet you get some basic understanding, but go see a professional who lives in the world and can help you make sense. What does that mean for your situation and your child?
Absolutely, and stays up to date in the latest research and recommendations.
Yeah.
Well, this has been really informative. Thank you so much for joining us today.
Yeah, my pleasure. Thank you.
It was very fun. Thank you everyone who watched and participated and sent in questions. You can catch us next Ask the Mayo Mom, a live video question and answer on June 21st at 11 a.m. Central Standard Time. My guest will be Dr. Erin Keeley, a pediatric physical therapist who is an expert in treating children with bowel and bladder dysfunction, such as prolonged bedwetting, incontinence, and constipation. And my second guest joining her will be Dr. Candace Gramberg, who is a pediatric urologist and also an expert in this area. Thank you, everyone, and have a wonderful day.